We are live now, sir.
Neelesh, shall I start?
Yes, sir. We are live now.
Okay. Thank you, Dr. Neelesh. Namaskar. Good evening to all. Behalf of Indian Society for Veterinary Medicine, I, Dr. C.N. Galdhar, welcome you all for today's webinar. Dear friends, today I am very happy to announce that young dynamic equine practitioner is with us and he is going to present today's webinar on practical tips for fluid and antimicrobial therapy in neonatal foals. Before starting the webinar, I would like to introduce about today's speaker. Dr. Swanand Sathe completed BVSc and MUSc from Bombay Veterinary College. In his MUSc thesis, he worked on bone scintigraphy in dogs from Department of Veterinary Medicine and Veterinary Nuclear Medicine in year 2003. After his MUSc, he worked at Mahalakshmi Racecourse as an equine sport medicine veterinarian. In year 2006, he got an opportunity to work for Poonawalla Stud Farm, which is one of the largest robot stud in India. In year 2008, he accepted an offer to complete an equine field service and reproduction residency program at United States of America. Dr. Sathe became board certified in equine reproduction in year 2010 and completed a second master MS in veterinary clinical medicine during his residency. He worked for university as a clinician for 1.5 years. Dr. Sathe worked as assistant professor of therogenology at Iowa State University from 2013 to 2019. Dr. Swanand guided more than 600 students at Iowa State University, trained 2 residents and 5 interns in field of equine reproduction and stud medicine. Dr. Swanand joined the Cambridge Equine Hospital, New Zealand as an associate veterinarian in late 2019 and where he currently enjoys practicing all aspects of equine medicine. His work span from advanced reproduction to neonatal care as diagnostic imaging of equine athletes. He holds special interest in topics such as mare infertility, neonatal intensive care, and management of high-risk pregnancies. With this brief introduction, I welcome Dr. Swanand Sathe sir to deliver his webinar on practical tips for fluid and antimicrobial therapy in neonatal foals. Thank you. Dr. Sathe, please. Just unmute yourself. Dr. Swanand, unmute yourself.
I am unmuted.
Yeah.
Can you hear me now?
Yes, yes.
Okay. Yeah, thank you, Dr. Galdhar, for that kind introduction. And I'm happy to be here with all of you. I would like to thank ISVM for giving me this opportunity to present my few tips and practice guidances for fluid and antimicrobial therapy in neonatal foals. A big hello and really a big thank you to all my senior colleagues as well as all the students that are watching this. I really love this topic. One reason is this is a very common topic that we used to kind of discuss with our students, interns, internal medicine residents as well in the United States. As well as prior to our breeding seasons, we always go through the fluid as well as antimicrobial therapy in neonatal foals. Especially right now in New Zealand, we have this breeding season going on. We actually have 3 foals in our hospital that require intensive care. So without further ado, let's start with fluid therapy in horses. There are several topics for today's discussion that I would like to kind of touch base on to get this discussion going underway. One would be the differences between neonatal versus adult physiology. We know that horses, or rather foals, are not mini adults, and we usually keep on stressing this point to our students when treating neonatal foals. Following which, we'll also discuss a brief a brief bit about clinical examination of foals to assess them for hypovolemia and dehydration. We would like to also discuss certain aspects of monitoring options that are available for foals in a hospital as well as field setting, especially pertaining to laboratory monitoring. And then what fluid choices do we have for administering to these neonatal foals? We would like to touch base on special considerations on certain electrolytes as well as glucose requirements for neonatal foals. And then lastly, we would finish off with aggressive or adverse effects of aggressive fluid therapy that can happen with overzealous fluid administration. So really, I mean, foals are not mini adults. They are nowhere near physiologically competent as adult horses. In adult horses, you can give them replacement fluids. You can give them your isotonic regular maintenance fluids at a high rate, and they still tolerate it well. However, foals differ quite greatly in their physiologic needs as well as their compartmental needs. So as you see in the table down at the right, foals usually have a higher total body water content, almost close to about 70 to 80%, as compared to adult equines, which average about 60 to 70% only in their total body water. Besides that, foals also have a higher extracellular component of fluids, almost close to 40 to 50% of the extracellular fluid component in their body is made up of water, as compared to adult equines, which comprise closely about 20 to 30%. Foals, on the other hand, all have a lower intracellular fluid compartment, about 30 to 50%, as compared to marginally high intracellular fluid compartment in adult horses. What this all means is that when you start intravenous fluid therapies in foals, these foals tend to redirect this fluid from their intravascular spaces into the interstitium. And what that also means clinically is that foals are more prone to developing interstitial pneumonia if you administer more or higher rate of fluids than what is recommended. Foals also have an increased capillary filtration rate and a large interstitial volume reserve. Hence, aggressive fluid therapy essentially increases the capillary filtration pressures. These capillaries then leak that fluid out into the interstitium, and then foals are at a high risk of getting interstitial edema. Foals also cannot handle these high pressures of fluids, nor can they handle high administration of sodium as adult equines can. Adult equines regulate their fluid volumes by excreting fluid very copiously through their renal output, as well as they excrete a lot of sodium, and hence it's difficult to cause hypernatremia in adult horses. However, foals are not capable of excreting this excessive fluid through their kidneys, as well as they also tend to retain a lot of sodium. If you guys remember your basic physiology in your first and second year of BVSC, our professors always used to say, where goes sodium, there goes water. And hence, if these foals retain a lot of sodium inside their system, they also retain a lot of water, and hence they are at a high risk of interstitial edema. Foals also have a lower colloidal oncotic pressure in their plasma, and hence, because of this lower colloidal oncotic pressure, they have higher hydrostatic pressures when you start pumping them with fluids, again, leading to edema formation. Higher surface area to body weight ratio is quite common in foals, which also means that they also have a higher rate of insensible losses. In short, foals require more water than adult horses do. And hence, when you're calculating fluid deficits for foals, you need to run fluids at a higher rate. But also remember the fact that you cannot run fluids overzealously because you can overload these animals quite easily. Premature foals have altered metabolism. Premature foals are not geared for adequate electrolyte balancing. They are not geared for adequate renal excretion of electrolytes. And at the same time, a lot of these premature foals, especially when they are sick, may be septic, they may have cardiovascular compromise, and hence these foals have altered metabolism to glucose, to electrolyte derangements, and they are more of a challenge to treat than regular neonatal foals. Foals also produce a lot of dilute urine. Foals, the foal diet is comprised 100% of the mare's milk in the early few days of their life. And hence, because of this high intake of water, they also produce a lot of water. foals produce an approximate 6 to 8 ml per kilogram per hour of urine, as compared to 0.5 to 2 ml per kilogram per hour of urine in adults. So, which also means that the more amount of milk they drink, the more amount of water they excrete. And hence, because of this high dilute urine, they also have high water requirements. One easy way actually to evaluate if this foal is getting well hydrated or if the foal is getting overzealously hydrated is to check his urinary specific gravity. Urine specific gravity in foals is isosthenetic to hyposthenetic. You can have urine specific gravity up to 1.009, at the most up to 1.015. Above that, the specific gravity indicates that this foal actually is conserving water. Plus, to make matters more complicated, foals are highly susceptible to infections, especially foals that have a failure of passive transfer are highly susceptible to infections. Infections cause sepsis. Sepsis causes cardiovascular collapse, as well as systemic inflammatory response syndrome. And in these foals, you have derangements, extreme derangements of electrolytes, as well as response to glucose. So let's discuss about some clinical signs of hypovolemia versus dehydration. So hypovolemia and dehydration are not synonymous terms. They are clinically different aspects of different conditions. Hypovolemia essentially indicates a lower intravascular fluid deficit, whereas dehydration indicates a deficit in the extracellular spaces, right? So hypovolemia essentially means lower circulating volume. If foals have a lower circulating volume, they kind of tend to collapse. Their cardiovascular systems are not geared to kind of pump in that extra stroke volume and keep their systems going. So in a lot of these hypovolemic foals, you will see an abnormal depressed mentation. When I do a lot of field practice. So if I'm out in the field looking at foals, and if I see a certain foal lying down for prolonged periods of time, or if that foal is not bonding with its mom, it's not following the mare around, we definitely go out and try to check the foal for signs of sepsis or hypovolemia. Because of hypovolemia, they also have poor peripheral pulses. You may have cold extremities because of poor hypoperfusion. Again, these foals tend to conserve a lot of water, obviously, because they have low water to begin with, and hence most of these foals will have a reduced to zero urine output. If you try to give them intravenous injections, you will see that they have a low or a reduced jugular fill and a prolonged capillary refill time of more than 2 seconds. As opposed to that, if you try to evaluate foals for dehydration, it is quite difficult to detect mild cases of dehydration in foals because foals don't tend to be as obtunded or as depressed as hypovolemic foals. They might actually try to run away from you. So in foals that are mildly dehydrated, sometimes it's very difficult to judge them clinically. You might want to observe them, get more history on them, or actually try and see if they are getting adequate milk supply from the dam. In moderate to severe cases of dehydration, you might get a reduced skin turgor or skin tenting. You can get tacky mucous membranes, dry corneas, sunken eyes. Sometimes these foals almost look like they have entropion in, bilaterally because of those sunken eyes, and of course, reduced urine output. So these are a couple of pictures of foals that were septic. On your left-hand side, you actually see foals that have injected mucous membranes. And that's an early sign of sepsis in foals. Besides injected mucous membranes, you might see hyperemic coronary bands on their feet. You might see fever. And on the right-hand side, you see a foal that has sepsis as well as hypoperfusion. You can see a marked difference between the mucous membranes. The right-hand side foal, of course, is more severely affected because of peripheral hypoperfusion. His mucous membranes are cyanotic. So what can we do to monitor these foals either in a hospital or a field condition? There are certain parameters that we can definitely evaluate that gives us the severity of this condition. It might give us a chance to evaluate the efficacy of a therapy as well. So the most common basic point of care monitoring that we do, especially in our hospitals. Did that in the US, we do it in New Zealand as well, is blood lactate monitoring. So blood lactate values in your system rise due to a response to anaerobic glycolysis, right? So if you have hypoperfusion, the body essentially tries to generate glucose through anaerobic means, and hence that gives rise to lactic acidosis, and hence leads to higher blood lactate concentrations. So if you have a high blood lactate concentration, it usually indicates that there's less tissue perfusion, there's less tissue oxygen consumption, as well as there's metabolic acidosis. Now, metabolic acidosis does not happen all the time with a high blood lactate. You can have a blood lactate of less than or up to 5 millimole without a metabolic acidosis. However, if you have persistently high lactate concentrations of more than 5 millimole up to 10 millimole, it usually indicates an ongoing metabolic acidosis is present as well. There have been several studies in adults as well as neonatal foals that have shown that a persistently high blood lactate concentration is related with high morbidity and high mortality rates in neonates. Now, once you start perfusing these foals with fluids, blood lactate usually starts coming down. So blood lactate could be a really good measure of evaluating your fluid therapy. Now, the next measurement that you could do is creatinine concentration. So creatinine will rise in the blood system, especially if kidneys are being perfused. So especially in foals that are hypovolemic, they will have a lower blood flow towards their kidneys, and that will raise the blood creatinine concentration in the system. Creatinine concentrations will also come down once you establish peripheral perfusion, once you start infusing fluids in these foals, and that's a really good measure to evaluate the efficacy of your treatment. Like we discussed before, foals produce a lot of urine and a lot of dilute urine. So one aspect of monitoring these foals is to monitor their urine output. In the hospital, we'll put urinary catheters in these foals, and we'll collect urine over a 12 to 24-hour period. We'll keep on checking the specific gravity of this urine. We'll also measure volume. So we measure the volume that's produced as compared to the volume that we are infusing inside these foals. So if once you establish a correct perfusion, once you correct the hypovolemia, once you correct the dehydration, these foals start producing hyposthenuria urine every couple of hours. Mean arterial pressure can be a very, very valuable method of monitoring the general circulatory mechanisms of these foals. Mean arterial pressures can be either measured directly or indirectly. If you have a foal that's happy up but still dehydrated, you could do an indirect measurement by putting a blood pressure cuff on its tail. We usually measure the mean arterial pressure on the coccygeal artery. If you have a foal that's more serious, if it's lying down, if it can't get up, then we put arterial catheters and we try to measure this mean arterial pressure. We try to maintain the mean arterial pressure above 60 millimeters of mercury. Usual average mean arterial pressures in thoroughbred foals, you average about 95 to 96 millimeters of mercury. Mean arterial pressure could be a very good way of monitoring whether the cardiovascular system is responding to your fluid therapy or not. Besides these parameters, we measure other parameters like packed cell volume, total proteins, total solids. In cases of septic foals, we do a CBC, a complete blood analysis. We like to do differential counts. We try to see for signs of sepsis like shift to the left. And then more critically, we measure glucose concentrations. Foals do not have high glucose reserves, and hence they become hypoglycemic within a matter of hours. So for example, for lactate, for glucose, you have these handheld meters that measuring devices that we use, which could be done even in a field setting. We provide a lot of information to us. So some guidelines that we can kind of discuss before we actually go to our fluid plan is for selecting appropriate fluids for neonates. Number one is always use 0.9% sodium chloride very sparingly. Now, we use this fluid quite commonly in our small animal medicine. We use it very commonly in adult horses. However, foals, because they cannot handle the sodium and chloride loads very efficiently as adults do, use 0.9% sodium chloride only in specific conditions. Like, for example, when foals have ruptured bladders and when they have high potassium content, those are the conditions where you would use 0.9% sodium chloride as a therapeutic fluid. For resuscitating these hypovolemic foals, we tend to use balanced isotonic electrolyte solutions, namely crystalloids, and which may or may not have dextrose. We usually always put dextrose in these because hypovolemic foals have not been nursing for a long time, and they, in more than 90% of the cases, are hypoglycemic. So we will add dextrose to these crystalloid fluids for resuscitation. Once you resuscitate this foal, you need to come up with a maintenance plan in order to keep this therapy going on. For maintenance fluids, we generally use hypotonic crystalloids, not isotonic, but hypotonic crystalloids with or without glucose. Never ever bolus concentrated glucose concentrations in foals. They raise that blood glucose up really high, and getting that hyperglycemia down can be a really long process. There is no benefit of bolusing foals with 10% or 50% glucose. Even foals that are flat out, that are hypoglycemic, that are seizuring, do not benefit from bolusing of high concentrated glucose. Also, do not bolus sodium bicarbonate, except in extreme cases where you have a foal that's essentially dying because of a low pH. There are no other indications for bolusing sodium bicarbonate. We tend to use sodium bicarbonate as an isotonic solution and not as such that's available in the market as a hypertonic solution. Sodium bicarbonate also has a high level of sodium that, of course, the foal cannot utilize efficiently. And with excessive bicarbonate administration, you run the risk of having metabolic alkalosis. In order to make sure that your therapy is not causing physiologic harm, we tend to monitor the electrolyte and glucose parameters very, very frequently. For example, if a sick foal comes inside the hospital, we will monitor its electrolytes or glucose every 2 hours until it's stabilized. And once it is stabilized, we might monitor it at least a couple of times a day. If you can use oral route of administration, if the foal is suckling, or if you can put a stomach tube or an indwelling stomach tube inside the foal and feed it milk, then that probably is the best fluid that should be going inside the foal. Mare's milk is a balanced electrolyte solution, and most of these foals do extremely well in terms of hydration and nutrition when mare milk is administered. All right, so what are the fluids that are available to us for resuscitating these foals? So, like I said, when we have a foal that's down with hypovolemia, we tend to use isotonic crystalloid solutions. The ones that are available in the market for us would be lactated ringers or Normasol R, or we get this solution. We don't get it in New Zealand, but in the States, we used to get a solution called Plasmolite 148. 0.9% sodium chloride only in specific conditions, like I mentioned before, and then isotonic sodium bicarbonate. For maintenance needs, always use hypotonic fluids and not isotonic fluids. So you can use half-strength sodium chloride with half-strength dextrose. You can use Plasmolite 56 and Normasol N. You can actually make hypotonic solutions using isotonic solutions by diluting them with sterile water, and we'll discuss this later on. You can use colloids for maintaining blood volumes. The biological colloids that we usually use in foals very often are plasma, and of course whole blood in cases of blood loss, anemia, neonatal erythrolysis. Some synthetic products that are available include pentastarch, hetastarch, and hemocele, except that there's not a lot of clinical evidence as well as clinical benefit in administering synthetic colloids to foals. Hence, we tend to kind of stay away from it. Also, these products are highly expensive, and if they're not giving us the desired clinical outcome, we tend not to use them. Again, There's various concentrations of glucose that's available. You have 5% glucose in water. You have 10%, 50% glucose solutions. We tend to use glucose very sparingly, or we tend to use low strengths of glucose. We might use 5% dextrose in water as an initial replacement therapy, or for maintenance, as well as we use the higher concentration of glucose to mix with our isotonic solutions and administer IV. Sodium bicarbonate, like I mentioned, is available as a 7% and an 8.5% solution, which is hypertonic, and we tend not to use this as a bolus. Instead, we'll convert that into a hypotonic or an isotonic solution and then administer it to correct metabolic acidosis. So how about we develop a plan to resuscitate a foal for hypovolemia? So imagine you have a foal that's presented to you, has poor peripheral pulses, has a prolonged capillary refill time, is obtunded, is flat out on the ground, and it's not responding. So what would be our first primary objective? Your first primary objective is to rapidly restore its circulating volume and reverse the shock process, right? So like we discussed before, our first fluid of choice to go to would be a balanced isotonic crystalloid solution. So usually we'll use a lactated Ringer solution for a plasma like 148 or a normal R. In some cases, we can use plasma as well, though we do not tend to use plasma as the sole fluid. This plasma tends to stay inside the circulatory system and draw fluid from the extracellular fluids, further dehydrating that fluid. So if we do use plasma, always make sure that you combine that with an isotonic fluid bolus. How much fluid can be administered? So in a hypovolemic foal, you can safely administer fluids almost up to 60 to 80 ml per kilogram. However, to begin with, we start with a 20 ml per kilogram bolus, run it over the first few minutes. For a 50 kilogram foal, that approximates about 1 liter of fluid IV. Just make sure that after each bolus, you're evaluating the foal's clinical responses. If the foal has started to respond positively, the foal's it will start keeping its head up. It will start maintaining external recumbency. You will start feeling strong peripheral pulses. You will see an increased perfusion. So capillary refill time wouldn't be prolonged. It would be less than 2 seconds. And this would indicate that this foal is responding appropriately or positively to your initial hypovolemic therapy. Now, in some cases, you may have to repeat this therapy several times, up to a point where you may need up to 60 to 80 ml per kilogram of fluid in the first few hours, or up to 4 liters of fluid. In some cases, there have been conditions reported where people have infused up to 200 ml per kilogram of fluid in the first 2 or 3 hours. If foals fail to respond to this extreme high volumes of fluid, then instead of trying to pump more fluids, you need to start resorting to ionotropic therapy by using dopamine or dobutamine. Otherwise, you risk the danger of drowning the foal or literally causing overhydration, right? So besides hypovolemia, foals also suffer from hypoglycemia, right? Foals have a very low reserve of glucose. When foals are born, they usually have a glucose reserve anywhere from 2 to 4 hours. If the foal does not feed in the first 2 to 4 hours, it becomes severely hypoglycemic and there's a chance of it collapsing down. So we need to provide fluid therapy for glucose support. So our goal is to maintain this blood glucose between 80 to 160 milligram per deciliter. Now, I have several colleagues who tend to go even a bit higher. Sometimes they'll go even up to 180 to 200 milligrams per deciliter. But I have found that when foals cross that 180 mark, they start excreting glucose in their urine, and thus they're using electrolytes as well. So I tend to stick to that 80 to 160 milligram per deciliter range. And the goal is to deliver glucose at the rate of 4 to 8 milligram per kilogram per minute. The reason why we have this rate is that studies have shown that equine fetuses, when they're inside the placenta, receive glucose from the dam at the same rate, right? So it's a physiologic rate of glucose metabolism in the foal. So if you deliver glucose at this rate, there is a little danger of causing hyperglycemia in this foal. So what fluids can be used for delivering glucose? Like I said, we can use 5% glucose in water. However, 5% dextrose tends to be metabolized very fast, and all that's remaining behind is water. And this water tends to accumulate in the interstitial space, causing edema. So what we tend to do is we tend to trick the system, and we use 50% glucose, and we actually dilute it with your isotonic fluids. Right? So again, for a 50 kilogram foal, if you have to deliver glucose at 4 ml per kilogram per minute, how are you going to do it? So that you need to multiply 50 by 4, which gives you approximately about 200 milligrams of glucose per minute, right? If you have to calculate this for an hour, multiply that 60 minutes, that's about 12,000 milligrams of glucose per hour using 5% dextrose, which is 50 milligram per ml. Now, if you want to give this over an hour, your fluid rate ideally, or if you need to give this over the 24-hour period, your fluid rate should be about 240 ml per hour. If you're using a 6 milligram per kilogram per minute infusion, you can tend to raise the concentration of glucose to 7.5%. If you're using 8 milligram per kilogram per minute of glucose, you can use the 10% dextrose range in order to deliver the same amount of fluid. Remember, you're delivering the same volume of fluid, which is 240 ml per hour, without increasing the volume, so that you're not causing any overhydration in these foals. So most foals respond very positively to glucose administration. Even compromised neonates, even sick foals respond very positively to glucose. They will start sitting up. They will start initiating the suckle reflex. They appear more bright. They respond to tactile stimuli. However, if you have very sick or compromised foals, these may either turn hyperglycemic or they may turn hypoglycemic. Hyperglycemia usually in sick foals is due to a slow insulin response. Most of these foals do not have insulin deficiency. They just have a slow metabolic response to the glucose that you're infusing. Some of these foals also continue to produce gluconeogenesis or glucogenesis. So the liver will constantly pump out glucose despite exogenous administration of glucose. And this usually happens in dysmature, premature foals or sick foals because their metabolism really has not caught up to this exogenous source of glucose that's been supplemented to them. In worst case scenarios, you have something called as a metabolic anarchy, where the foal has completely failed to transition metabolically to extrauterine life, and hence they cannot regulate their blood glucose very efficiently. And in those cases, these foals tend to become hyperglycemic. Now, a reverse case scenario would be hypoglycemia in the sick or compromised foals. And one reason for hypoglycemia, despite pushing glucose inside their system, is a hypermetabolism. These foals are trying to maintain their body systems. They may have fever, they have a high metabolic rate, they may have systemic inflammatory response syndrome or SIRS. And in those cases, they are just utilizing that glucose more faster than what you are supplementing them. And hence, I bring this point back again. You need to monitor these foals for blood glucose concentrations periodically to make sure that your therapy is efficient. Okay. These foals also can suffer from metabolic anarchy, like I said before, because of the failure of metabolic transition. It's usually termed as neonatal maladjustment syndrome, right? So what can happen because of hyperglycemia? Because of hyperglycemia, you can have cellular dehydration. Cellular dehydration can sometimes lead to certain aspects like brain swelling, brain edema, without an insulin response. But we are more concerned about glucose diuresis. If you are pumping more glucose inside the system, foals tend to excrete this glucose through their urine. And of course, glucose being hygroscopic takes a lot of water and electrolytes along with them. So if you have a hyperglycemia, these foals keep on losing water and electrolytes in their urine despite you pumping more water in them. So essentially, you're just back to square one, where you have a foal that'll keep on getting dehydrated because of hyperglycemia. Mild hyperglycemia with glucose less than 250 usually does not present with glucose diuresis. Most of these foals kind of just are slow to respond. We need to give these foals certain amount of time, several hours sometimes, for them to mount an insulin response in response to your glucose administration. Most of these foals do really well. However, if you have a foal with glucose diuresis, you can suspect that they have certain issues with adaptation. They may have a slow insulin response or a zero insulin response, and that's when you decide to initiate an insulin therapy. Remember, even though you're initiating an insulin therapy, you're not stopping your glucose infusions. You have to reduce the amount of glucose that you can infuse in these foals. However, zero glucose infusions does not do these foals any good, because they are dependent on this glucose for nutrition, right? So insulin therapy is kind of a gray area, especially among a lot of practitioners. We have students that graduate and then become practitioners, and a lot of these students are kind of very wary of using insulin. They are afraid that they might push more and they might crash the foal. However, most foals actually tolerate the insulin therapy really well. You need to give them a continuous rate infusion or a CRI instead of giving them bolus injections, right? So, like I said, most insulin infusions are in response of an insulin deficiency versus an insulin resistance. Most foals usually have an insulin deficiency. Compromised foals may have an insulin deficiency or a slow insulin response rather than peripheral insulin resistance. And even septic foals will respond adequately. If you're providing the adequate amount of glucose and adequate amount of insulin, they'll kind of turn around over several hours and they will respond really well to your therapy. In foals that have neonatal metabolic maladjustment, these foals are particularly challenging because no amount of glucose or no amount of insulin that you push in tends to kind of fix them. But again, like I repeat, just be patient, give them several hours, not several minutes, but several hours to respond to your therapy. So how do you use insulin? We use regular insulin. We do not use the long-acting Lent insulin. The dose can vary. Dose usually starts from 0.00125 to 0.2 units per kilogram per hour. So we start usually at a lower dose. And then and again, you need to keep on monitoring the blood glucose in these animals. If you're seeing that your therapy is not working, you need to double the rate of infusion every 4 to 6 hours until the glucose levels stabilize, right? Again, do not panic, do not push too much insulin in these patients because you can cause a reverse hypoglycemia. Give them several hours to respond to your insulin therapy, right? One way, and by doing this, you essentially avoid what is called as a glucose roller coaster. The roller coaster goes up and down. Similarly, if you keep on pushing glucose and then keep on pushing insulin, you're causing reflex hyper and hypoglycemia, which is detrimental to the foal. Again, if you're using insulin, I'm not going to go in great detail, but I would like to point out that you need to take every care that's recommended for handling insulin. Like, for example, it needs to not touch plasticware or glassware for too long. You need to dilute insulin directly inside the solution. Preferably use colloidal, or preferably use plasma to even sometimes prime the line before running insulin inside it, so that the insulin does not stick to the plastic. So anyway, I'm not going to go into great detail, but make sure that you take all precautions for handling insulin. Right, so now you have stabilized this foal, you've corrected the hypovolemia, you've corrected the glucose deficiency. How about going and maintaining this foal on fluids now? So maintenance in foals can be very challenging, and there are quite a few several factors that can provide this challenge to these neonates. One would be differences in metabolic rate. So sick versus septic versus near normal foals will have different aspects of metabolism. Septic foals will have a higher metabolic rate. They'll utilize glucose more. They'll utilize electrolytes more. Hence, they have higher need, as opposed to foals that are almost near normal. Gestational age makes a big difference on how foals respond to your therapy. There are some foals that are at a full gestation length are more mature to adapt to differences in electrolyte derangements. Ambient temperatures, if it's too cold or too hot, it leads to more insensible losses in foals, and hence these foals might need more fluid. Breed or surface area to mass ratio, growth rate, or underlying disease processes, all of these factors will provide a big challenge to maintenance fluid plans. There is no single correct maintenance fluid plan. There's no one formula that fits all, right? So every foal is different, every case is different. There are certain guidelines that I can provide you, and you need to tailor make that to your patient in order to provide them maintenance fluid requirements. Again, if you have a foal with diarrhea, if there are ongoing losses, that foal is going to need a higher requirement of maintenance fluids. And in foals that do not have these ongoing losses, you also run the risk of causing tissue edema. Remember, I talked to you about how foals cannot handle excess sodium or excess electrolytes, and they tend to kind of compartmentalize fluid in the interstitial spaces. So you do risk having the edema formation in these foals, especially foals that have perinatal asphyxia syndrome. So you have a double-edged sword. If you give too less fluid, you cause dehydration, cause brain injury. If you give too much fluid, you cause overhydration, cause edema formation, leading to seizures. So to counteract all these challenges, there is a formula that's very popular that's used among neonatal foals. It's called as the Holiday-Segar formula, and it is also known as the dry maintenance rate concept. And it's quite popular in full fluid therapeutics because it gives fluids very sparingly and reduces the risk of edema in these foals. So what's the Holiday-Segar formula? So this formula was developed actually for human infants less than 100 kilograms of age in the late 80s. So the formula essentially is made for weights that are less than 100 kilograms. So the formula goes like this. So for the first 10 kilograms, so 1 to 10 kilogram body weight, you supplement fluid at the rate of 100 ml per kilogram per day. For the next 10 kilograms, you supplement fluid at the rate of 50 ml per kilogram per day. And then for the rest of the kilograms that are remaining based on the body weight, you supplement fluid at the rate of 25 ml per kilogram per body weight. So if we have to calculate this for a 50 kilogram foal, and I keep on stressing on the 50 kilogram foal concept because most of our newborn foals, when they're born, are roughly around 50 kilograms in body weight. So for the first 10 kilograms of body weight at the rate of 100 ml per kilogram per day, you're looking at 1 liter of solution. For the second 10 kilogram body weight, after calculating at 50 ml per kilogram per day, you're looking at half a liter or 500 ml. And for the remaining 30 kilograms, you're giving fluid at the rate of 25 ml per kilogram per day, which roughly calculates as 750 ml. So your total fluid requirements for 24 hours usually comes to about 2,250 ml per day, or roughly 94 ml per hour, or approximately, to keep things simple, we would like to give this foal 100 ml of fluid per hour. The beauty of this this formula essentially is that it provides just enough fluid to meet the maintenance requirements without overloading this whole system and causing edema. However, you do have challenges with foals that have ongoing losses. So this formula cannot be used in foals that have, for example, diarrhea. So for ongoing losses, you can supplement foals at a higher rate, almost up to 4 to 6 ml per kilogram per hour, right? The Holiday-Segar formula provides fluid at a much lower rate at 2 ml per kilogram per hour for maintenance. So if you have to replace or provide maintenance fluid, you have to keep certain key points into consideration. Again, number one, use hypotonic solutions that have osmolality between 112 to 150 milliosmol per liter. You can start at 4 to 6 ml per kilogram and then reassess your therapy. You can reduce the therapy or reduce the rate if your foals looks like it's getting edema. You can see that picture on the right-hand side. The reason we call that as a jelly foal is it's got this excessive amount of facial edema due to overzealous fluid administration, and because of which its face seems swollen. You can increase your rate if you have a foal that starts developing diarrhea, or increase your rate essentially with ongoing losses. Monitor your sodium or serum sodium values very closely. Monitor your urine output very closely. Keep your specific gravity of urine between 1.003 to 1.016. And then also monitor for frequent urination. Most foals should urinate almost 1 to 2 times per hour. And above all, monitor for edema formation. Okay. So I'm just going to discuss very briefly certain electrolytes. Dr. Galdhar, how much time do we have? Okay. Let's start with sodium. Foals do not need an excessive amount of sodium. Mare milk is a poor source of sodium, and hence we tend to give them just enough sodium to get by. Potential problems of supplementing more sodium is hypernatremia, which is more difficult to correct. So sodium, you can have hypo or hypernatremia. Regardless of which condition you have, you should not correct these deficiencies or excesses at more than 0.5 milliequivalent per hour to prevent central nervous system disorders, right? So if you have a hyponatremia with a foal that presents seizures, you can start immediately administering sodium chloride at a higher rate till the seizures stop, and then pull down the amount of fluid that you are administering to this foal to 0.5 milliequivalent per hour to keep up with the ongoing losses. Similarly, with hypernatremia, you can have cerebral edema if you correct these deficits, correct this hypernatremia at more than 0.5 milliequivalent per hour. And the fluid for choice for treatment of hypernatremia is 5% dextrose or half-strength saline with half-strength dextrose. Okay. Potassium is required by foals in relatively high amounts because mare milk is rich in potassium. And if this foal is not being supplemented with oral milk, then they require more amount of potassium. Potassium chloride can be given at the rate of 10 to 40 milliequivalents per liter in maintenance fluids. If you have a foal that has a hyperchloremia, then you can supplement potassium phosphate instead of potassium chloride. And again, just like sodium chloride, you have to supplement at the rate of 0.5 milliequivalent per kilogram per hour and not more. Some of the most common disorders that happen with potassium are hyperkalemia, especially in foals that have bladder ruptures, or renal failure, or hyperkalemic periodic paralysis, or adrenal insufficiency, or rhabdomyolysis. Right? So in those cases, we need to counteract that hyperkalemia by providing 0.9% sodium chloride, like I had mentioned earlier, and you can supplement that with 20 ml per kilogram of calcium at the rate of 0.4 to 1 ml per kilogram of 23% calcium gluconate. In addition to that, you can also add glucose to drive potassium back into the cell at the rate of, again, 4 to 8 milligrams per kilogram per minute. If you do not want to use sodium chloride, you can alternatively use isotonic sodium bicarbonate with calcium that can be supplemented separately. Insulin can be given in refractory conditions or severe hypercalcemia to drive the potassium inside the cell, and 0.005 to 0.01 unit per kilogram per hour of IV insulin is given to drive this or correct this hyperkalemia. So how about calcium? Calcium derangements are rare in foals, except in cases of parathyroid dysfunction. rapid administration of sodium bicarbonate or correction of alkalosis can bind your ionized calcium to albumin. That can cause hypocalcemia. So foals require supplementation of fluids with calcium gluconate, and we usually give that at the rate of 1 ml, 0.2 to 1 ml per kilogram in 1 liter of fluid once. And then you recheck your blood parameters to make sure that they indeed are hypocalcemic before providing an extra dose. Hypomagnesemia is fairly common in sick foals, and we can supplement or correct this deficit by administering magnesium sulfate at the rate of 4 to 16 milligram per kilogram over 4 to 6 hours, and then you need to monitor subsequent levels. Like I mentioned, sodium bicarbonate is available as a hypertonic solution. You can make an isotonic solution of sodium bicarbonate by mixing 150 milliequivalent of sodium bicarbonate per liter of sterile water. Do not bolus this sodium bicarbonate in hypovolemic patients for the fear of causing alkalosis, and it's mainly used to correct base deficits. So if you want to calculate how much of bicarbonate to supplement a foal, you can do that by multiplying the body weight in kilograms to the base deficit on your blood gas analysis and multiply that with 0.4. The amount that you get in milliequivalents of sodium bicarbonate can be given, half of that amount can be given IV, and the rest of that amount can be given over the period of 12 hours to correct your base deficit. So complications of sodium bicarbonate are hypokalemia, hypocalcemia, especially that of ionized calcium, metabolic alkalosis, and hypocalcemia. I decided to include additional formulation of maintenance fluids. Sometimes in certain countries, you may not get replacement fluids like those isotonic fluids that I mentioned about. So in those cases, you can actually make certain replacement fluids based on the amount of fluids that you get. For example, you can mix 5% dextrose in water with replacement fluid in a 1:1 ratio, and that essentially makes that solution half-strength dextrose and half-strength isotonic solution. Or if you do not need dextrose, you can actually mix replacement fluids with sterile water. For example, you can mix reverse lactate with sterile water and come up with a half-strength reverse lactate that can be given to foals more safely than an isotonic reverse lactate solution. Also make sure that you always mix sterile water with fluids before administering. Do not administer sterile water directly intravenously because that can cause hemolysis due to its hypotonicity. Some complications of fluid therapy, like I mentioned before, if you push in too much of fluid too fast, you can have pulmonary edema. You can run the risk of having brain swelling. You can have oxygen delivery to tissues due to tissue edema. You can have electrolyte derangements such as that of sodium, potassium, and calcium, leading to metabolic alkalosis and acidosis. Sometimes overzealous fluid therapy can result in hemorrhage. And then, of course, because you have long-term IV catheters inside these foals, you always run the risk of thrombophlebitis and sepsis in these foals. So, do you have any questions, or shall we continue with that? Do you have enough time for antimicrobials in foals?
Yeah, we can continue.
Okay, all right. Because I know I'm over time right now. I'm just about halfway done, but I just wanted to make sure that you guys were fine with that.
No, Dr. Swanand will just explain about the antibiotics, okay?
All right, so I'll continue, right?
Yeah. In short, just explain it.
All right, thank you. So we'll start with antimicrobial therapy in neonatal foals. So we have differences between the neonates and adults. So we have to consider those differences when using drugs in foals. We have bacterial species, certain bacterial species that commonly affect neonatal foals. And then there are certain factors like route of infection or location of that infection that we consider while selecting antibacterials for these foals. And then there's always this question about which antibiotic should I use as first line of treatment in a field setting where I do not have culture and sensitivity results. So that's again a topic of discussion, and then we'll discuss some brief antibiotics that are most commonly used in neonatal foals. So there are certain physiologic considerations that you need to keep in mind. For example, the dynamic dose regime. Essentially, it means that foals gain body weight every single day. They may gain up to 1 kilogram of body weight. When you're using drugs like aminoglycosides in foals, you need to account for the change in body weight and adjust your dose regimes accordingly. Otherwise, you can risk the chances of antimicrobial toxicity. Because foals are not hindgut fermenters like adult horses, their bioavailability, oral bioavailability of certain drugs is higher, and which is a big advantage to us because we can give certain drugs orally and then ensure that they are bioavailable much more readily than adult horses. Because foals also have a higher volume of water in their and low volume of fat in their body composition, the variability in volume of distribution of certain drugs, for example, like aminoglycosides, can vary, which also means aminoglycosides need to be dosed at a higher rate in foals than in adult horses. Because of low protein concentrations, you have higher instances of free or unbound drugs. Free or unbound drugs are the active form of drugs because they're not bound by albumin, and hence certain drugs need to be dosed at lesser frequent intervals because they have higher because they have higher peak concentrations inside the foal system. Again, foals may have a decreased metabolic or excretory capacity because they have a insufficiently developed hepatic and renal system. They may not be able to eliminate certain drugs, or the half-life rather of certain drugs may prolong in the foals, and you need to take that into account. Otherwise, these foals run a chance of having toxicity to certain antibiotics. Foals also have a acidic pH to their urine as compared to adult horses that have alkaline pH, and then that's the reason the reabsorption of weak acids is much greater in foals, and there's a greater elimination of weak bases like trimethoprim sulfur, for example, is readily excreted through urine in foals. So there were two studies that were done, very famous studies that were done that essentially tried to isolate or pinpoint what bacterial species are commonly associated with the neonatal foal. There was one study out of Stone Equine Hospital by Jane Axon and others, and they actually evaluated culture samples from 427 critically ill neonatal foals over a 5-year period. I'll talk about this in very brief. Essentially, the crux of that study was that they found that E. coli or Enterobacteriaceae family was one of the most common isolated organisms that affects neonatal foals and that causes sepsis, followed by gram-positive bacteria like Staphylococcus and Enterococcus. There was another study, a recent study in 2012, that's out of Spain, that was done in 10 foals with bacterial meningoencephalitis. And again, similar to the earlier study, they found E. coli to be one of the most important causative organisms affecting foals. And this is not surprising because E. coli is found pretty abundantly. It's found in soil, it's found in environment. And if these foals are housed in unhygienic conditions, then these foals tend to become more susceptible to E. coli infections, especially if the umbilical cord is not infected or disinfected or treated well. There are other negative species that are found equally that affect and cause septic infections in foals, namely Enterobacter and Klebsiella, gram-positive pathogens like staph or strep species, and then there are some less commonly associated microorganisms like Clostridium, Salmonella, Pseudomonas, and Actinobacillus species. Regardless of these bacteria, whenever a foal comes in a hospital in the States, in New Zealand, some colleagues in Australia who also vouch for this, is that it's a standard practice to send blood for blood cultures for any critically ill foal that comes to a hospital for admission. That way you can tailor-make your antibiotic therapy based on cultures and sensitivities. So what are the factors that determine what antimicrobials should you select? So of course, the first antibiotic that you would select probably should depend on what's isolated on your blood culture ideally before an antimicrobial therapy started, but that's always not the case. For example, I go out in the field and I see a sick animal. I usually treat it with antibiotics before referring it to the hospital. So in most cases, you will have a foal that comes to the hospital pre-treated with antibiotics. So in those cases, if you have a foal that already has been treated with antibiotics, you can use a system called as the Sathe check system. And essentially, this system removes the antimicrobial from the blood, and then essentially you can proceed with your blood culture and get more appropriate results. So blood cultures have to be obtained from external veins or peripheral veins using strict aseptic technique. If you break aseptic techniques, you essentially are taking a contaminated sample, and that may skew the results of your blood culture. Besides blood, you can take samples from peritoneal fluid or pleural fluids, or in cases of septic arthritis, synovial fluid, or in cases of respiratory infections, transtracheal washes, or spinal fluid may also provide you more information along with your blood cultures. In cases of septic arthritis, we highly recommend that blood and synovial fluid both should be tested in order to get a clear picture of what pathogens are involved. Always be aware of false positives, especially if you have not scrubbed the area or if you have not maintained aseptic techniques while obtaining blood samples. You do run the risk of having false positives. Or if the animal has been treated with antibiotics prior to getting a blood culture, you do run the risk of having false negatives. So you need to decide or you need to evaluate the results of your samples appropriately based on your clinical case. So based on the site of infection, you can try and select certain antibiotics. We know that antibiotics need to have or achieve high concentration or high MIC values at the site of infection, right? So based on what systems or what body systems are involved, you need to tailor make or you need to infuse antibiotics locally in some cases to maintain those high MIC values. For example, in septic arthritis, we recommend doing a systemic as well as local antibiotic therapy. Systemic therapy, yes, it will raise your MIC values in plasma, but sometimes because of the structure of the joint, you may not achieve good penetration of antibiotics within the joint capsule. In those cases, we do use local antibiotic therapy. For example, you can repeatedly flush this joint with antibiotics almost every day or every other day for repeated flushes over several days. We do something called as IVRP or intravenous regional perfusion, where you tie a tonic wet above the region of interest and infuse antibiotics intravenously below the tourniquet to achieve a good tissue concentration. We do surgical debridement of infected synovial membranes. In extreme cases, you need to do a synovectomy and then put in impregnated beads with antimicrobials within the synovial cavity. If you're dealing with meningeal infections or CNS infections, you need to use drugs that can actually penetrate the blood-brain barrier. For example, aminoglycosides will affect most of the organisms that cause meningitis, but aminoglycosides do not penetrate the blood-brain barrier, and hence they are a poor choice for treating foals that have meningitis. Good choices for treating foals with meningitis could be chloramphenicol, trimethoprim sulfa, or third-generation cephalosporins. In cases of pulmonary infections, again, you need to have a localized high concentration of antibiotics within the lungs or pulmonary parenchyma, and hence we use nebulizers. There's a full nebulizer that's available from a company in Canada that can be used to achieve high concentrations of these antibiotics within the pulmonary parenchyma. In addition to that, we also use systemic antibiotics. So route of administration will also dictate which antibiotics should you select. Like I said, mentioned earlier, oral antibiotics are better absorbed in foals than in adults. So you do have choice of giving oral antibiotics in foals. However, we have few choices in equine medicine. Foals also have a less muscle mass, so you can't keep injecting intramuscular injections in foals repeatedly like you could get away with in adult horses, which can be extremely painful and provide a big discomfort to foals. Hence, IV route is the most preferred way of delivering antibiotics. You can put in long-term IV catheter. We sometimes train our owners to take care of the catheter, appropriate catheter care. Training has to be given so that you do not it does not result in a thrombophlebitis or catheter-related infection. But that's the best route of achieving good MIC values on foals. Foals are also susceptible to potential toxicities. If you have a foal that is immature, has ongoing sepsis, this can further lead to lowered metabolism of antibiotics, leading to a prolonged half-life and subsequent toxicity. Make sure that foals are not dehydrated if you're especially administering aminoglycosides, because they can be nephrotoxic. And then fluoroquinolones are known to cause cartilage damage in the foal. Hence, drugs like enrofloxacin or ciprofloxacin should not be administered in neonatal foals because they will cause joint damage. And then, of course, the length of treatment is very important. The length of treatment essentially depends on the body system that's involved. For example, foals with meningitis need to be treated for at least 4 weeks so that you get rid of all the infection from the choroid plexus. Otherwise, these foals keep shedding that bacteria even though they are clinically normal. In cases of Rhodococcus equine infections, for example, foals need a prolonged antimicrobial therapy for up to 6 weeks. So we need to adhere to those specific guidelines depending on what kind of infection that foal has. So for first-line treatment of infections, these are certain things that you need to keep in mind. There was a study that was recently done. It was a retrospective study done in 2019 by Thielen et al. And they concluded, based on numerous data that they got from different hospitals in the United States, that early institution of antibiotics in sick foals is beneficial to greatly reduce the morbidity and mortality rate. Right? So there's a big concern always in the veterinary community about indiscriminate use of antibiotics. However, foals being immunocompromised, foals being relatively less developed physiologically than adults, do benefit from first-line treatment with antibiotics. Again, based on the organ system that's involved, you need to take an educated guess. We talked about what bacteria are involved in neonatal infections, so you need to take an educated guess of what underlying pathogens could be involved. Historic data supports that most infections in foals occur due to gram-negative sepsis. Right? So you need to use intravenous, broad-spectrum bactericidal drugs as the first line of treatment in foals. Do not use bacteriostatic drugs in foals. Combinations of penicillin with an aminoglycoside are thought to provide the best coverage for most common organisms. And again, the recent study that I mentioned before indicated that ampicillin combined with amikacin has been reported to provide the best combination for initial therapy. This combination targeted more than 90% of foal pathogens. Right? Some combinations to avoid largely are combinations of bactericidal and bacteriostatic drugs. For example, penicillins and tetracyclines, or penicillins and chloramphenicol should not be used together as first line of treatment. So aminoglycosides are one of the most commonly first line treatment drugs that are used in foals. They have a primarily gram-negative spectrum and with a very few select gram-positive spectrums as well. They act synergistically with penicillins, and the thought process behind it is that penicillins, being beta-lactamase antibiotics, will destroy the cell wall of these bacteria, and that provides aminoglycosides greater penetrability inside the bacteria and to cause damage. Neonates, because of their high body water content, require a higher dose of aminoglycosides than adults. And like I mentioned before, they have very poor penetrability through the blood-brain barrier or into deep-seated infections like abscesses or into bone in cases of osteomyelitis. So do not use aminoglycosides when foals are suffering from meningitis or abscesses or osteomyelitis. Amikacin is the drug of choice due to its lower nephrotoxicity among aminoglycosides and low bacterial resistance. And dosing is quite high in foals at the rate of 20 to 25 milligram per kilogram. It can be combined with penicillins like ampicillin, like I mentioned before, and it is the first line of treatment, especially for burn infections. However, amikacin is extremely expensive. It is prohibitively expensive over here in New Zealand, as well as, if I remember well, in the United States as well. And hence, we use the poor man's amikacin, which is gentamicin, as our first line of treatment until we actually get our blood culture results that indicate that amikacin has to be used instead of gentamicin. Gentamicin has a good spectrum of activity, not as wide as amikacin, but it just does fine. It does really well with combinations with penicillin and cephalosporin, and it's relatively cheap. Penicillins have been historically used for many years to treat infections. They target mainly gram-positive organisms, and protein penicillin G is used quite commonly, especially in adult horses, intramuscular injections twice a day. Adult horses start becoming sore with neck swellings, and hence we prefer not to use PPG in foals because of their lower muscle mass and their sensitivity to protein salts in penicillin. We prefer to use potassium and sodium salts of penicillin intravenous, and especially potassium salts have to be given slow intravenous, otherwise foals react negatively to the potassium penicillins. Amoxicillin and ampicillin also have a good gram-positive as well as gram-negative spectrum, and ampicillin, again, combined with amikacin, is thought to be the most effective combination that targets more than 90% of neonatal microorganisms. There have been reports of using continuous route infusions of IV penicillins in a hospital setting. And the advantage with continued CRIs of penicillin is that they provide really high MIC as well as peak values of the drug in the body system to counteract severe septic situations. Extended spectrum penicillins are reserved only for pseudomonas infections like carbanicillin, ticagrelin, and piperacillin. I've used carbanicillin maybe once in my life on a confirmed pseudomonas case. Again, these antibiotics are not very commonly used, and hence I'm not going to discuss them too much in detail. Cephalosporins, again, a second beta-lactamase class of antibiotics, and they actually have better tissue penetration, but poor intracellular access. Hence, they cannot be used for intracellular microorganisms. They are excreted partly via biliary route, and hence they can cause neonatal diarrhea. And first-generation cephalosporins have the advantage that they can be given orally with high bioavailability. Second-generation cephalosporins are similar to first. Third-generation cephalosporins, namely ceftiofur, is the most commonly used antibiotic in foals, has a good gram-negative spectrum, sometimes can also be used alone. In a recent study, they found that almost 80% of organisms were susceptible to ceftiofur infusions. If you have an E. coli sepsis, which probably is the most common organism that does affect neonatal foals, ceftiofur dose rates have to be increased 2 to 3-fold. So the label dose rate usually says 2 to 4 milligrams per kilogram body weight, but with E. coli sepsis, ceftiofur has to be given at the rate of almost 10 milligrams per kilogram IV twice a day. The advantage of ceftiofur is that it can be given intramuscularly or subcutaneously. And that is really good for us because clients can administer it at home if they're taught how to get this drug to their foals. There's a formulation, I don't know if it's available in India as well, called as Exceed. And Exceed is a crystalline free acid formulation of ceftiofur. It is a long-acting antibiotic, can be administered every 2 to 3 days. The drawback of Exceed, however, in foals is it causes big swellings and hard swellings in foals. At the same time, it takes several hours, about 6 to 8 hours for Exceed to reach MIC concentrations in foals, and hence it should not be used as a first-line treatment in septic animals. Third-generation cephalosporins like cefotaxime and so can be used for treating bacterial meningitis since they penetrate the blood-brain barrier very well in foals, as well as they're effective against anaerobes. Fourth generation cephalosporins like ceftriaxone, cefepime have been used in Europe. There have been several reports of their successful use in neonatal sepsis in Europe. However, we have not been fortunate to have access to them yet. Fifth generation cephalosporins have not been tested in horses yet, and hence we won't discuss them in this presentation. There are certain antibiotics that can be used for treating anaerobes as well as deep-seated infections, and of them, metronidazole can be used for treating anaerobes as well as antiprotozoal infections, namely Giardia species in foals. Metronidazole has excellent bioavailability in foals. We actually get metronidazole in form of a paste, and that can be given twice a day to foals, especially effective against Clostridial enteritis caused by Clostridium difficile in foals. Tetracyclines have both gram-negative as well as gram-positive spectrum. However, they have a very limited use for the first-line treatment. We use tetracyclines in long-term osteomyelitis cases, especially doxycycline is used for osteomyelitis that requires several weeks of therapy. The most commonly used form of tetracyclines is oxytetracycline in foals for correction of flexural deformities and knot point infections. However, we tend to dilute it with water while giving it IV, otherwise it causes thrombophlebitis. The last antibiotic of this group is chloramphenicol. It is usually reserved, especially for treating abscesses or treating osteomyelitis infections or for treating meningitis-like infections, because it has a great penetrability in the blood-brain barrier and achieves good MIC concentrations in CSF fluid. It has a great anaerobic spectrum and is also effective against enterococcus isolates that affect foals, especially. Fluoroquinolones, like I mentioned, are bactericidal. They penetrate well. They have excellent activity against gram-negative bacteria and staphylococcus isolates. However, they also cause cartilage toxicity and arthropathy in foals, and hence enrofloxacin and ciprofloxacin especially should not be used in foals. There's a new drug called as marbofloxacin that has been used occasionally in foals, and so far the authors have not reported any adverse conditions on, especially pertaining to joints in these foals. And further, I guess research is underway for treating foal infections with marbofloxacin. I'd like to point out a study that was done, interesting study that was done out of Illinois in pregnant mares, where they treated pregnant mares with placentitis with enrofloxacin. They found that enrofloxacin achieved a really high concentration in placental fluids, and they found no cartilage damage in the foals that were born to these mares. They radiographed these foals up to 2 years of age, and they found no evidence of cartilage damage due to enrofloxacin that was treated during pregnancy in these foals. The last antibiotic is imipenem. I have not ever used this antibiotic. However, it is reserved for highly resistant infections in horses. It is 100% efficacious against bacterial isolates from neonatal foals. However, it is cost prohibitive, as well as it is reserved only in highly resistant bacterial infections and when culture sensitivity takes. So these are my references for today's talk, and I really thank all of you guys for showing up today, and from the ISVM for giving me this opportunity to present my talk to you. I'm happy to take any questions if you have any.
Thank you, Dr. Sathe. Really for the extensive presentation.
I apologize for going 20 minutes over the time limit.
Yeah, no, it's acceptable because you have covered antibiotic and fluid therapy. First of all, really, we are thankful for accepting our invitation. And it is odd time for you at New Zealand, and in odd time also, you are delivering this webinar in the forum at the forum of Indian Society for Veterinary Medicine and giving some tips, practical tips for antibiotic at the same time, fluids and other things.
It's
I'm
my pleasure. Thank you so much.
happy to announce that there are some beautiful comments available in the chat box, that some people, they are telling that this is the really informative presentation. Some people, they are enjoying.
Thank you
Again,
very
one
much.
person, he finds some difficulty to join our webinar. It may be a network issue and other thing. I'm sorry from the organizing committee if because of this internet glitch and other thing, it caused you some difficulty to join the webinar. Dear Dr. Sathe, again, I would like to highlight one important thing. Today, senior ISVM members like Dr. S.U. Digraskar sir, Dr. Umesh Dimri sir, Dr. G. Vijay Kumar sir, Dr. S.P. Wagmare sir, Dr. K.S. Pajai sir, and Dr. Nitin Bhatia sir, they have joined. The young
Thank you.
ISVM members,
Thank you,
Dr. Suresh Patel, Dr. Meera Sakre, Dr. Pankaj Kumar, Dr. Rajesh Agrawal, Dr. R.K. Bharadwaj, Dr. Gautam Bhojne sir, and Dr. Sunil Ahire. He is also joined for today's webinar. And I am very happy that more than 100 students, they have joined for the today's webinar. With this,
I'm
there
really
are some
grateful.
questions.
Thank you.
Yeah,
Yes.
thank you. Some questions are there.
Yes.
One question is there from Dr. Ali. He is requested from, he wants, what are the conditions we use fluid for just newborn foals to get resuscitate and other thing?
For new ball folds, if you need resuscitation, you can actually use 5% dextrose in water.
Okay, only 5% is sufficient.
5% again, if it's just for resuscitation, as in if it's not hypovolemic, depends on how what the degree of hypovolemia is. If the foal is indeed hypovolemic, like I mentioned, you need to use your isotonic crystalloids along with dextrose in water for resuscitation. But if the foal just needs a quick pickup, sometimes these foals are slow and they just need this quick pickup, and in those cases you can just infuse a D5 with water, and that kind of stabilizes their glucose values, and then these foals essentially start brightening up really well.
I think there is one from Dr. Sujit Kumar. Okay, that is willing to ask, does hypovolemia and dehydration coexist?
Does hypovolemia and dehydration coexist? They can overlap to some extent because in foals, for example, because they have a large extravascular kind of interstitial reserve, they sometimes tend to pull that water in the intravascular spaces in order to try and compensate for hypovolemia. And in those cases, you can have a brief period where you can have a foal that's hypovolemic as well as dehydrated, because it's trying to draw that fluid from the extravascular fluid spaces into the intravascular compartment in order to keep its system going. Yes, so theoretically, yes, you can have hypovolemia and dehydration both present at the same time. Yep.
Again, there is a question from Dr. Naveen. Sir, please guide antibiotic recommendation for salmonella infection in foals.
For salmonellosis. Essentially, we tend to use aminoglycosides primarily, but at the same time, salmonellosis can sometimes be a tricky kind of infection. It's kind of sometimes even a self-limiting infection in which you need to provide a lot more fluid support, intensive care to animals like adults as well as neonatal foals. We do give metronidazole to counteract anaerobic infections that do arise due to salmonellosis, but we tend to stick to aminoglycosides, primarily gentamicin.
Again,
we'll send fecal samples for, of course, for antibiotic and sensitivity cultures, but our first line therapy is gentamicin in salmonellosis.
Okay, again, Dr. Sujit Kumar sir, he has posed question in chat box. What are diseases or disease condition where hypovolemia could be predominant or prominent?
Well, if you have excessive fluid losses, so if you have a foal that's got severe diarrhea, where it's losing more fluid than it's consuming, then you can have a hypovolemic condition. If you have a foal with fever, with a lung infection, or with any kind of sepsis that prevents that foal from nursing its mother and getting its nutrition, all of these essentially conditions can cause hypovolemia in foals. So anything that prevents the foal from actually going and deriving nutrition from its dam in any situation can prevent hypovolemia, can cause hypovolemia.
Again, sir, there is one question from Pankaj Hase. Throw some light on hemoprotozoan infection in foals.
On what?
Hemoprotozoan infection in foals.
Hemoprotozoans. I'll be really honest. When I was practicing in India, I have seen horses with babesiosis and trypanosomiasis, but in the last 15 years, I have not seen any hemoprotozoan parasites, especially in the US or even in New Zealand. But I can probably talk about a bit about babesiosis in horses. So we tend, if I remember right, we used to treat horses with babesiosis with imidocarb. In cases of trypanosomiasis, imidocarb is indicated theoretically, but I remember we used to treat horses with this combination of drugs that contained quinopyramine sulfate and quinopyramine chloride. I think it was marketed for camels, I believe, but we used to treat horses for trip in India with that combination. I forget the name of the trade name of that drug. But I'll be honest, I haven't seen hemoprotozoan parasites or hemoprotozoans in horses in the last 15 years. I'm really sorry about that. A bit rusty on that knowledge.
Again, sir, there is one question. Are foals hypovolemic?
Are foals born? Yeah.
Hypovolemic always?
No, foals are not technically born hypovolemic. Now, there are certain conditions where the foals can get hypovolemic at birth. For example, when foals are born, there's a high supply of blood from the maternal side to the fetal side through the umbilicus. And if there's a premature separation of the umbilical cord, then these foals may be deprived of some of that blood supply that can contribute to hypovolemia. Or if the foal has undergone a dystocia, prolonged dystocia, and cannot get up and nurse in time within those 2 hours, then the foal can get hypovolemic. But traditionally, foals are not born hypovolemic as such. They have an adequate blood, like circulating blood.
There is a question from Dr. Naveen Kumar again. Sir, could we use metronidazole and aminoglycoside in combination as IV inputs?
You can use them in combination, but don't mix them.
Okay.
You can use both these drugs together in horses to combat infection, but don't mix them together. Metronidazole should not be mixed with aminoglycosides.
Okay. Thank you. Any questions? Please let me know. I have collected almost all questions and communicated to Dr. Sathe. Okay. Dear Dr. Sathe, we are really very thankful to you. At last, I would like to request Dr. Sunil Wagmare, sir, to offer the vote of thanks for today's webinar. And again, there is one announcement from my side. Next Saturday also, one request. Who is there whose mic is not? Please unmute mic. Neelesh, who is that gentleman? Please let me know.
Dr. Sanjay Mishra.
Okay. I do request Dr. Wagmare, sir, to offer vote of thanks. Wagmare, sir, please. Sir, please unmute yourself, sir. Wagmare, sir, please unmute yourself.
Okay, thank you very much, Chandrakan. Good evening. On behalf of Indian Society for Veterinary Medicine.
Sir, just a minute, sir. Sir, just a minute. Two questions are there. They are from Dr. Sauro Naskar.
And
I will take two questions. What is the treatment of orchitis in foal?
Treatment of orchitis in
Yeah.
foals.
Yeah.
If you have orchitis, they usually have, well, I mean, it causes severe inflammation. You can try combinations of penicillin and gentamicin in cases of orchitis, because due to inflammation, you have greater penetrability of these drugs inside the testicular parenchyma. However, there have been reports of use of doxycycline long-term, not in foals, I'm talking about adult horses. There also is, you can also use enroflox. Again, in adult horses, I have not seen orchitis in foals, to be honest. But any drug that is lipid soluble and has a greater penetrability, even tetracyclines, for example, could be used for treatment of orchitis in foals. Again, you need to maybe take testicular aspirates and try and send them for antibiotic testing and culture before you essentially narrow down your spectrum of your microorganisms. But I would, my first line of treatment would be penicillin and gentamicin. Because I think because of that inflammation, those antibiotics are going to still penetrate the testicular parenchyma.
Thank you.
Yep.
Dr. Sathe. I request one more, sir. Thanks. Sorry for those two questions. They have, it means available in my chat box at last moment. Okay. One more, sir, please. Sir, unmute yourself first.
yeah. So, on behalf of Indian Society for Veterinary Medicine and our college partner, Zydus Animal Health, I extend my sincere thanks to specialist in equine reproduction, Dr. Swanand, sir, Associate Vet, Cambridge Hospital, Cambridge, New Zealand, for accepting our invitation as a speaker for today's webinar on the topic practical tips for fluid and antimicrobial therapy in neonatal foals. As in spite of his busy schedule, as now the breeding season is going on in the New Zealand, and I know it's very important season and very busy season, and in spite of that, he presented his topic on the practical tips for fluid and antimicrobial therapy in neonatal foals. So, as well as the criteria for selection antimicrobial therapy in neonatal foals. Once again, I am thankful to Dr. Swanand Sathe sir for delivering explain and interpreted how therapy is important in foals. To all of us while treating the foals. Thank you very much, sir, for presenting the topic. I'm also thankful to our dean for his encouraging support of today's webinar and the series of webinars organized by this ISVM. I would like to thanks to Dr. Ramprabhu. I'm also thankful to our knowledge partner, Zydus Animal Health. I am also thankful to all office bearers and executive members of ISVM. I would like to thanks to webinar moderators, his event coordinator, especially Dr. Chandrakant Galdhar, Professor, Mumbai Veterinary College, MAFSU, Dr. Neelesh, Sindhu, social media in charge, LUVAS, Dr. Sujit Kumar, Head of Technical and Promotion, Zydus Animal Health, India. I am also thankful to Dr. Shanker Singh for help regarding session and certificate. I am thankful to Dr. Singh for technical support and especially Dr. Neelesh, Dr. Vijay, Jadhav, Dr. Sumit, Mahajan, Dr. Kumar for their technical support and help. I am especially thankful to all the veterinarians, equine practitioners, and students for participating and joining today's webinar. All members of ISVM also, I'm thankful to all the members, especially today Dr. Umesh Dimri, Head Division of Medicine, IVRI, Dr. Digreskar sir, Dr. Bhatia sir, Dr. Vijay Kumar sir, all the members of distinguished members of ISVM, they joined today's webinar. Thank you very much, sir. I'm also especially thankful to Dr. Zulfikar Ali sir, Equested Farm. He is a very renowned equine practitioner. He joined today's webinar, and to Dr. Zulfikar Ali sir. And last but not the least, I am thankful to all those who have rendered help and support for organization of today's webinar on the topic practical tips for fluid and antimicrobial therapy in neonatal foals. Thanks to I declare this webinar is over. Over to Chandrakant.
On Indian Society for Medicine Forum. It's on poultry medicine. I do request all the participants to join that webinar. Thank you. Thank you very much. Thank you everyone for joining the ISVM webinar. Thank you. Thank you, Dr. Swanand.
Thank you.
Thank you.
Bye.
Yeah, bye. Good night.
Good night.